الحمد لله.
الحمد لله سلامتك يا بيه.
بس هما كل
دكاترة احنا هنبدأ بس.
طب اوكي خلاص اوكي.
Good evening. We are now going to start our webinar for interventional procedures in Obstetrics and Gynecological Ultrasound. From Assiut University, under the patronage and the attendance of DevartLab, we broadcast for you this webinar. Actually, we would start with thanking too much the cooperation of the team of DevartLab for introducing this webinar. We are very happy today to have two very well distinguished speakers. Our first speaker will be Professor Ahmad Nasr from Assiut University, and the second speaker is Dr. Hisham Elgammal, as you all know, a very distinguished speaker from Alexandria University. Now we are going to start our first lecture with Professor Ahmad Nasr, talking about the interventional procedures in ultrasound, in gynecologic ultrasound. Let us start.
السلام عليكم ورحمة الله وبركاته. دكتور حسن بيه، طبعا أنا شاكر تقدمة حضرتك ودعوة حضرتك الكريمة. Dear Professor Hassan, Chairman, colleagues, ladies and gentlemen, it's again a great privilege and honor to be invited. Thanks again to Professor Hassan for such a courteous invitation. And I will be briefing you over the next 30 minutes or so on some aspects of gynecological ultrasound procedures, concentrating mainly on SIS as well as many other topics. So first of all, let's be reminded how the evolution of ultrasound has been a very successful story. It all started way back in 1957 by Dr. Ian Donald, a physician, and engineer Tom Brown, who was an engineer. Such a collaboration between a physician and an engineer came up with the development of the currently available ultrasound machines. It all started in Glasgow, Scotland, and in the late 1950s, it became kind of routine in most Glaswegian hospitals. So this is on the left-hand side is Dr. Ian Donald and Tom Brown, who is an engineer. So the evolution started with very large, cumbersome machines and developing into the very well-designed, sophisticated machines we are having today. And it's even getting more smarter, from the standard size to the pocket size, connected to the internet, and those with the very lively interactions and the dynamic ultrasound machines we are having currently. So has been the development of the literature pertinent to ultrasound. It all started with Ultrasound in Medicine and Biology, which became the official journal of the World Federation for Ultrasound in Medicine and Biology since 1973, with the latest impact factor of over 2.5. And moving on to our specialty, Ultrasound in Obstetrics and Gynecology, which is the official journal of the International Society of Ultrasound in Obstetrics and Gynecology since '91, with an impact factor of over 5.5, ranking 5th on the list of OB GYN journal, a very distinguished position. So let's move on to a very short list of the gynecological ultrasound procedures, starting off with sonohystrography, ultrasonography in relation to assisted conception, PCOS surgery, ectopic pregnancies, pelvic cysts, gynecological cancers, the HIFU procedure, and as well as many other applications. So sonohystrography entails imaging of the uterus aided by real-time transcervical infusion of a contrast medium. Sonohysterosalpingography is sonographic imaging of the fallopian tubes and determination of the patency, again by using a real-time transcervical infusion of a contrast medium. The HIFU procedure is a simple, well-tolerated outpatient ultrasound procedure done for the tubes as well as to detect abnormalities of the uterus and endometrium. The test requires the use of a contrast agent to enhance visualization. We can also use a kind of foam, which is called a HIFU procedure, and the HIFU procedure is safe and reliable. It is considered an alternative to conventional HSG using X-rays. No radiation is used in such case. We will put and shed some light on saline infusion hysterosonography or SIS procedures. The SIS procedure entails transcervical introduction of saline, provides enhanced endometrial visualization during transvaginal sonographic examination, with the potential benefits of being easy to perform with a minimal cost and being very well tolerated by patients, and luckily attended with very few, if any, complications. So the indications start with AUB or abnormal uterine bleeding, infertility and recurrent miscarriage, congenital abnormalities of the uterus, pre and post-operative evaluation of uterine pathologies, where suspected uterine cavity synecdoche, and where TVS examination proves inadequate. Known contraindications, which are quite the same as HSG, are pregnancy and active pelvic infection. So moving on to the first indication of SIS, which is abnormal uterine bleeding. It accounts for many outpatient as well as inpatient visits, and the diagnostic procedures that currently available are TVS, endometrial biopsy, hysteroscopy, and the seldom used DNC biopsy. Here I refer to one of the earlier papers of Professor Hassan way back in 2000. They were really pioneers coming up with this study published in the ACTA. And they tried to evaluate the value of SIS in abnormal uterine bleeding with a sensitivity and a specificity which has been significantly more accurate than TVS examination. So SIS can help distinguish anatomic AUB from anovulatory bleeding, and in cases of postmenopausal bleeding from atrophy. It may also help select candidates for endometrial sampling. It can also differentiate focal lesions necessitating biopsy under direct vision versus a global blind procedure that can be sampled otherwise. Now, as far as infertility, assessing the endometrium is again part of a routine infertility workup, as well as a recurrent pregnancy loss workup. So a submucous myoma is well delineated, endometrial polyps, uterine anomalies, and intrauterine adhesions. SIS compares favorably or even better than HSG. Again, one of the references from our institution, whereas HSG has been claimed to be better at outlining the fallopian tubes. So in conclusion, SIS in infertility is a highly sensitive and specific test in the diagnosis of uterine polyps, submucosal myomas, uterine abnormalities, and intrauterine adhesions. It can also be used for screening of infertile women prior to IVF ICSI. As far as the technique, it is scheduled somewhere between day 5 and 10 of the menstrual cycle. Usually no anesthesia or a minimal analgesia is required. Before performing a bimanual exam, a speculum exam, and aseptic prep of the cervix. So start off by a flush catheter. We insert the catheter even without the need for a tenaculum, and they fill the balloon just very much like a Foley catheter, snug the catheter nicely against the internal os. Then we remove the cervix, attach a 10 milliliter syringe of sterile saline, and then insert a TVS probe. And this fluid is then instilled, exploring the long axis plane, turning the probe 90 degrees, and instilling more fluid to have a view of the coronal plane, which stems out like fanning from the endocervical canal all the way up to the fundus. And this is what a normal SIS looks like, with the balloon inflated. And this is how a polyp looks like. TVS for abnormal bleeding revealed an ill-defined mass, and SIS here on the right side demonstrated a fundal polyp very nicely and clearly. So here again, a polyp removal. See how marvelous this is. A polyp after being removed under ultrasonic guidance, leaving a perfectly normal endometrial cavity. Here again, what happens if we have a multiple polyps here in this 52-year-old woman with abnormal bleeding, and SIS has shown that with considerable accuracy and outlining. Moving on to the cancerous polyps in this 71-year-old woman with postmenopausal bleeding, finding from the blind endometrial biopsy before the SIS were negative, whereas the SIS procedure turned out to be more clarifying as far as the image of the cancerous polyps. The characteristic submucosal or submucous myomas, stage or FIGO staging 0, 1, and 2 are very nicely delineated by SIS here again, as those two red arrows have shown how they project into the endometrial cavity. Tamoxifen-related bleeding disorders, here TVS has shown irregular endometrium and cysts, whereas SIS has shown the subbasalis cysts characteristic of such a condition. Moving on to the very common endometrial pathology of hyperplasia, endometrial hyperplasia, you can see how nicely this is depicted, showing endometrial thickening and multiple cystic areas as shown by the arrowheads. Pathology examination, which has been performed later on, has shown a simple endometrial hyperplasia. Endometrial hyperplasia here again in this 54-year-old woman with menorrhagia showing areas of focal thickening of the endometrium. Now, what about endometrial cancer? Is it helpful? In this TVS picture, an endometrial thickness of 7 millimeters, just slightly above the upper limit of normal, and the SIS has clearly demonstrated the endometrial pathology, and biopsy of which revealed a well-differentiated adenocarcinoma. Metastatic cancers, here again in this 71-year-old woman with postmenopausal bleeding and history of breast cancer, has shown the focal mass very clearly by SIS procedure. Adhesions again in this relatively young woman undergoing a fertility workup with previous 2D and CS procedures, which most probably have not been carried out properly, and SIS has shown a poorly distensible endometrial cavity with adhesions as suspected by the arrowheads on the right-hand side. So what are the technical difficulties and potential complications of such a simple, minimally invasive procedure? They all start with passing the catheter because of cervical stenosis, an abnormal uterine position, or a uterine abnormality, to poor visualization, being unable to retain fluid due to a patulous cervix, and the threaded and the dreaded infection risk, as well as which is quite the same as HSG. So cancer dissemination has been a potential threat, which has been not founded actually, but one important issue is the false positive results. It can be attributed to blood clots or air, as I'm going to show you in the coming slide. So this is one of the situations where inadvertent injection of a small amount of air, which appeared as a right echogenic focus in the fundus region of the endometrial cavity, which is an artifact, of course. And blood clots can mimic a mass, like this very interesting series of pictures. In A and B, patient had postmenopausal bleeding. A mass has been shown in A and B, very suspicious ones, where color Doppler imaging, as shown in picture C, have shown no color flow within the mass. After dislodgement, the image very happily became a normal endometrium. So a prospective study of over 1,100 women aged 23 to 64, all of whom have undergone SIS, came with some important data. Failure to complete the procedure was only encountered in 7%. Let's see how feasible this procedure is. Pelvic pain was experienced in less than 4, vagal stimulation in less than 4, nausea in just 1%, and post-procedural fever in less than 1%. So it's quite an interesting and a valuable tool. So let's bring SIS in a nutshell. SIS provides enhanced endometrial visualization. It improves sonographic detection of polyps, hyperplasia, cancer, myomas, and adhesions, can help avoid invasive procedures, and may optimize preoperative evaluation for those women who require therapeutic interventions. Moving on to the role of interventional ultrasound in assisted reproductive technologies, which I would like to say was the first actual interventional ultrasound in gynecology. Adoption of the interventional ultrasound in gynecology was through the ART. So the well-known transvaginal oocyte retrieval is currently performed under TVS guidance with an attached needle that is inserted through the vaginal wall all the way into an ovarian follicle, taking extra care not to injure neighboring organs, and the other end of which is attached to a suction device. And once the follicles entered, suction is gently applied to aspirate the follicular fluid and hopefully all oocytes. The technique is known to most of us who practice ART, a very simple procedure, but it's very useful to use ultrasound technology in this widely practiced therapeutic modality for infertility. So moving on to embryo transfer, there has been quite a bit of debate whether or not to use ultrasound while performing the procedure of embryo transfer. Let's be frank, saying that embryo transfer is one of the rate-limiting steps in IVF success. It is operator dependent, and pregnancy rates do differ much depending upon the performing physician. There is now good evidence based on 9 RCTs that transabdominal sonographic guidance while performing embryo transfer improves the chance of a live birth, ongoing and clinical pregnancies, as compared with the other technique, which is called the clinical touch, without increasing the potential chance of pregnancy, of ectopic pregnancy, or a miscarriage. This is a grade A recommendation, a very strong one. So the technique here, I don't want to go through details, but there is definitely a certain spot where the embryos should be dislodged at to maximize the chances of pregnancy. So what's the value of ultrasound guidance in IUI? Intrauterine insemination, again, is a very simple procedure, which usually is done before in as many as 4 trials before the eventual resort to ICSI. So in IUI, it was found to improve pregnancy and also reduce the frequency of IUI failures. Moving on to role of ultrasound in minimally invasive ovarian ablative surgery for PCOS, and I would like to recall that surgical intervention for PCOS, such a common endocrinopathy, is only a second-line management. It's not intended to be a first-line management at all because of many issues, top of which is not to encroach on the ovarian reserve and to cause iatrogenic adhesions. So when it is properly indicated, what's the role of ultrasound as a minimally invasive procedure in ovarian ablative surgery for such a common disease? Using transvaginal ultrasound-guided procedures, ovarian stromal hydrocoagulation to reduce the mass of thecal cells, or ovarian interstitial laser treatment, or ovarian needle drilling, all of which have been described in many literatures, and they have been used quite frequently. Now, what are the other indications? There have been quite a breakthrough in the use and utilization of gynecological ultrasound in many interventional procedures in our current gynecological practice. I will just mention a few. Puncture of simple ovarian cysts, aspiration of an ectopic pregnancy with or without administration of methotrexate, fallopian tube recanalization, and I would like to say sterilization too, pelvic congestion treatment, ultrasound-guided transvaginal endometrial biopsy in cases of cervical stenosis, and ultrasound-guided transcervical ablation of uterine fibroids. Moreover, ultrasound-guided treatment of intrauterine adhesions as an aid to histoscopy ultrasound-guided aspiration of hydrosalpinx fluid, ultrasound-guided drainage of supralevator and infralevator pelvic hematometer, ultrasound-guided installation of a sclerosant, what's called a sclerotherapy in management of adnexal masses, and 4D ultrasound-guided injection of botulinum toxin A in some cases of chronic pelvic pain. Intraoperative introital ultrasound during a Birch corpus suspension procedure carried out for stress urinary incontinence. We still have a long list. Ultrasound-guided aspiration of ovarian endometriotic cysts, a point of considerable controversy. Ultrasound-guided drainage of pelvic abscesses. Ultrasound-guided ethanol injection for abdominal wall endometriomas. Ultrasound-guided IUD insertion, and likewise a difficult removal of a retained IUD. See how the diversity of the use of ultrasound in gynecological practice has been. Perhaps this is only the tip of the iceberg. We have still to wait for the coming years for a lot of more indications. So I would like to comment on the transvaginal ultrasound-guided aspiration of endometriosis. And here I came with a very recent publication that's only 2 months old in the Journal of Obstetrics and Gynecology Research, a group from Spain. They came up saying that do not use, it does not offer TVS-guided aspiration of endometriomas, is not recommended, okay? This is a final recommendation. This comes in agreement with the earlier recommendations of the American societies and the European societies. So please, TVS-guided aspiration of endometriomas is not to be recommended. So moving on to high-intensity focused ultrasound, the HIFU procedure. It's still an early stage of medical technology. The mechanism is much like a use of a magnifying lens, focused ultrasound using an acoustic lens to concentrate the intersecting beams on a specific target, usually a myoma, sometimes adenomyosis, and others. So each individual beam passes through the tissue with a little effect, but at this specific point where the beams converge, the energy can have useful thermal and mechanical effects, very much like laser. So the HIFU is typically performed with real-time imaging via ultrasound or the magnetic resonance guided focused ultrasound or the MRG focused ultrasound. So the HIFU ablation of uterine fibroids, how far have we gone through this road? It is a non-invasive alternative for some women with fibroids. It still has many contraindications, advantages of which are a very low risk of complications and a very rapid recovery to normal activity in just 1 day. So it is a 1-day surgery. If it is surgery, it's a very minimally invasive procedure. It is not recommended for women. This is quite important. So in women who wish future fertility, fertility cannot be guaranteed at the present time. And these are the recommendations of all fertility societies. So kindly be noted that if a woman is desirous for pregnancy, do not resort to the HIFU procedure. This is as far as the technique. It has been approved by the FDA in 2004. But it has been limited to 10% of the fibroid size. And what about the follow-ups? At 6 months, there was just a 15% reduction in size and over 70% reduction in symptoms. After 2 years, there was just an extra 4% reduction in size and a 50% reduction of symptoms. But unfortunately, over a quarter of these women chose to go for a hysterectomy, a myomectomy, or uterine artery embolization procedure, which tells you that it is not very satisfying for clients. So the HIFU therapy for treatment of adenomyosis, we have heard Professor Bidewi a few days back talking about adenomyosis very nicely, and he has mentioned he has come across the HIFU therapy. Again, it's not standard, it's not first line, it's only experimental, it's new, promising, yes, in some patients with adenomyosis, and the HIFU treated patients who wish to conceive showed a high conception and live birth rates, which is quite pleasing for researchers in infertility. However, its efficacy, safety, cost effectiveness and fertility outcomes must be evaluated by properly designed RCTs. So it is no more than an experimental trial, which might hold promise at the end of the tunnel. So HIFU procedure has also been described for some vulval dystrophies, not just the fibroids or the adenomyosis. Moving on to devices which use the ultrasound technologies, not principally an imaging procedure, but it utilizes the ultrasound principles. So that's why I kind of put it in the list here. It's the CUSA or the Cavitron ultrasonic surgical aspirator, which a surgical site reduction for epithelial ovarian cancer, used very successfully in palliative resection of recurrent gynecologic malignancies involving the vagina, and with a laparoscopic nerve-sparing radical hysterectomy, which is again very widely practiced abroad. So let's be reminded, Professor Hassan, that half our medical knowledge is not true, the problem knowing which half. So we might be seeing only the tip of the iceberg. And this is not a blackout, this is not a power failure. This is only to tell you that in the middle of darkness, it's very easy to miss your step. So we still have a long way to go to decipher the potential ever-growing list of benefits of ultrasound in gynecology. Let's be reminded that the magic is in the magician, not in the wands. So it's definitely Professor Hassan's hand, for instance, that really make a difference rather than the machine he is using. So in a nutshell, Professor Hassan, ladies and gentlemen, dear colleagues, I would like to reiterate some important issues as far as ultrasound, which is a real innovation. It's a very useful device at low cost. It's a very trainable experience. And thanks to the training center established by Professor Hassan at our distinguished university, it's a very repeatable and reproducible type of procedure. It's available, it's ubiquitous, it's available everywhere. You can hardly find a place without an available ultrasound machine. Yes, it's safe. There are very few complications attended with using an ultrasound machine. It can be used for both operative and diagnostic, obstetrics and gynecology. It has unified standards because we've been using unified tables, norms that make not only the procedure more easily done, but also makes comparison of studies, establishing research works a lot easier and more reliable. And it's a very neat type of investigation. It doesn't use radiation. And last but not least, let's pay tribute to Professor Dr. Ian Donald, who brought this nice technology to light. So my take-home message, Chairman, ladies and gentlemen, from A all the way to F. An ultrasound machine is a must-have. It's very valuable both in obstetrics and gynecology. It's almost complication-free. It can be used for both diagnostic and operative procedures. And since we are talking about procedures this wonderful evening, so these procedures are very happily, unfortunately, easy to perform. They are very rapidly executed, but let's be reminded that they all depend on a gifted operator, just like Professor Hassan. Thank you very much indeed for your attention, and I hope this has covered some aspects of gynecological interventional ultrasound.
Thank you, Professor Ahmad, for this wonderful presentation. Actually, it's very effective, and you provided us with a very special type of knowledge. I think you provided us with a very nice lecture. One of the those I seldom hear like this, actually. Thank you very much, Dr. Ahmad. Professor Ahmad, as always, you are distinguishable. And now we are waiting for your next lecture as a presentation for DevartLab message to us today. Now you can go.
Okay, thank you, sir. Okay. So I will be with you in a minute. Well, ladies and gentlemen, here again, I hope I'm not too much talking, but I will get straight to the point here. Thank you for your invitation, Professor Hassan, and for the Devart company for your courteous invitation. I will be talking about antioxidants in a woman's reproductive life, moving on from theory to practice. So let's be reminded how proud all of us are being OB/GYN specialists, because the obstetrician gynecologist is a very observant type of person, keeping the interests of both baby and mother in the back of his mind or her mind all the time, is very generous in time and effort, is always asking why, and this is why we are here tonight, to uncover the secrets related to our practice. And last but not least, because nobleness is the sine qua non of our profession, the hallmark of our practice. So what really makes a good presentation? I will take the words of Winston Churchill, the former Prime Minister, English Prime Minister, who said that it should not be too long or too short. So I would like to start with the founding members of the EFRI, the Egyptian Foundation of Reproductive Medicine and Embryology, which I'm honored to be one of those distinguished professors. And let's start with a lot of secrets related to antioxidants, right? Not only in the context of antioxidants, but from the perspective of female reproduction. Back to physiology, oxygen in cellular metabolism. Let's see how important oxygen is to each and every human cell. But oxygen is not always a blessing. It might be toxic. And let's be reminded how an excessive oxygen dose can be detrimental to a newborn retina, for instance, with a retrolental fibroplasia. And if oxygen was just perfectly safe, we wouldn't have needed oxygen regulators, for instance. So allow oxygen to flow in as much as you can, in whatever concentration, nothing really matters. But this is not the case. So what is an oxidative stress? So it occurs where free radicals are toxic parts in the body that are left over after oxidation. Let's compare those to an exhaust of a car engine, right? And those are the waste a cell makes after energy consumption and energy production. It depends on how the body is able to detoxify to get rid of the ROS, which stands for the reactive oxygen species. If this results in a state of imbalance, then we'll end up having what's called an oxidative stress or damage to proteins, to molecules, to genes. So very much like this, if we're having a pro-oxidants which have the upper hand to the antioxidants, we'll end up having an oxidative damage or an oxidative stress. Is oxidative stress a normal process? Yes, in fact it is. But the body reacts very nicely and very rapidly to get rid of the reactive oxygen species, just like getting rid of the waste products. But just have a look at these apples and how the oxidative stress breaks them down, causing premature aging and disease. So here again, what are free radicals? Free radicals are unstable molecules with an unpaired electron. They are highly reactive because they search for stability. And to be stable, they have to take electrons from other molecules, which brings damage to a number of tissues. The sources of oxidative stress are pollution, infection, smoking, insecticides, food additives, stress, diseases, and drugs. Oxidative stress affects the entire body. Is that statement correct? Yes, it is. It actually affects the entire body, but we'll be concentrating over the next slides on as far as female reproduction. What about oxidative stress and women? It is related, in fact, to PCOS, to abortion, to tubal infertility, to endometriosis, as well as other autoimmune or immune-related disorders, unexplained infertility, vesicular moles, to embryopathies, and to a poor outcome during ART. Now, what about oxidative stress in OBGYN? It is, in fact, a very important subject, not only for those women who are willing to get pregnant, but also during pregnancy and thereafter. So what are the reproductive complications of oxidative stress? Very shortly, they can be related to infertility, abortion, whether habitual or threatened abortion, or some adverse pregnancy outcomes like preeclampsia. So, in short, the oxidative stress results in a reactive oxygen species overproduction with reproductive implications relating the oxidative stress to some gynecological pathologies and obstetric complications like PCOS, endometriosis, preeclampsia, fertility decline, menopause, unexplained infertility. And last but not the least, a whole list of pregnancy complications like fetal growth restriction, preterm labor, spontaneous abortion. In ART, likewise, there is a greater instance of failed implantation secondary to a reactive oxygen species overdominance or an oxidative stress. So what are the complications of oxidative stress in women? The role of female infertility and assisted reproduction by Ashok Agarwal, a very known gentleman. I mean, he has one of the highest H scores ever in medicine, stemming from Cleveland Clinic, the very well-known figure. So the oxidative stress and its role in female infertility and assisted reproduction. Maternal circulation is established by the end of the third trimester, and there is an oxidative stress birth within the placenta, and the abnormal placenta, due to various causes, leads to oxidative stress. So oxidative stress has been related to recurrent pregnancy loss. Here again, it has been related to abortion and preeclampsia, where aberrant placentation causes placental ischemia, leading to the generation of placental oxidative stress, which is a key role in the pathophysiology of spontaneous abortions, preeclampsia, and fetal growth restriction. Now, what about preterm birth and preterm infants? Here again, absence of appropriate micronutrients have led to maternal complications, not only maternal complications, but also neonatal complications. Topping the list are preterm birth, preterm infants, small for gestational age, and many other complications. So here again, placental malperfusion results in fetal growth restriction through a multitude of factors: smooth muscle oxidative stress, and infarctions, suppression of protein synthesis, pro-inflammatory cytokines, and trophoblast oxidative stress. So the complications of oxidative stress in women have been related to placental dysfunction with the eventual evolution of abortion, vesicular mole, recurrent pregnancy loss, drug-induced fetal teratogenicity, and preeclampsia. So how to manage oxidative stress? We have to have the antioxidants overpowering the amount of free radicals to correct such a stress reaction. How to manage is through lifestyle modifications, regular exercise, acquittance of smoking, having a healthy diet, and last but not least is to give antioxidants. Which antioxidants to give? So without antioxidants, the body is something like this car going uphill, which can be really challenging. So the role of antioxidants can prevent oxidative attacks of free radicals, making the free radicals more stable, and less dangerous to the body. As far as the types of antioxidants, we have endogenous antioxidants like superoxide dismutase or SOD, glutathione, and catalases, or an exogenous source of antioxidants like selenium, zinc, omega-3, alpha-lipoic acid, and vitamin E. So if we have a look at the potential sites where antioxidants can function to have a positive impact on the reproductive system of a female, it's the hypothalamus and the higher centers. It's the ovary with all the dynamics of ovarian activity. It's the endometrium with all the changes, not that, but also the peritoneum and the whole list of immune-related interactions. So we might look to antioxidants as a very useful additive, just like this additive is added to your motor or your engine. It adds a lot to the performance of the engine, here in this case to each and every human cell. And in our partner talk, cells related to reproductive functions of a woman. So are they good for just a woman? Of course not. They are very good for both, for men and for women alike. Now, how do antioxidants interact with the circadian reproductive clockwork? We look at the reproductive functions as a very intricate and very well synchronized activity, very much like clockwork, even better still. So there is circadian variations occurring in the 24-hour period of a day, an example of which is the pulsatile release of gonadotropins, of GnRH to start with, gonadotropins, and the hormones. Not only this, but also the antioxidants, they come to kind of fine-tune this nice machinery. So any role of antioxidants in female infertility, in fact, there is. This is the big challenge, a very proportionate picture of how small a sperm is as it approaches the gigantic oocyte and it's ready to invade. So, as far as IVF, let's be reminded by the words of Louis Pasteur, who said that chance favors only the prepared mind. Nothing really comes by chance. The sudden flashes of insight don't just happen, but are the product of preparation. And the perfect example of that is Louise Brown, who is almost 43 years. In 2 weeks' time, she will be 43, the world's first IVF baby, with a current estimate of over 8 million IVF ICSI babies around the world. So what are the relations of antioxidants to female infertility? Antioxidants, again, can reduce the oxidative stress in the follicular fluid of women undergoing IVF, increasing the number of good quality oocytes recovered at ovum pickup. It has also been demonstrated that ovarian stimulation induces the reactive oxygen species production and perturbation in the oxidant-antioxidant balance, leading to oxidation stress. Therefore, high plasma antioxidant level was associated with a higher number of total and mature oocytes, and thereby the number favorable for achieving pregnancy or cryopreservation of embryos. In accordance with this study, which has been authored by Professor Bidewi, our sincere colleague in Canada, previous reports have shown that follicular fluid total antioxidant capacity is positively correlated with the pregnancy rate. A very strong recommendation. So what about the role of antioxidants in improving oocyte quality? A very important factor in recurrent implantation failure. Recently, a diet which is rich in omega-3 fatty acids is an effective and practical avenue for delaying ovarian aging, improving egg quality, and extending a reproductive lifespan, even at an advanced maternal age. Low-dose aspirin and omega-3 fatty acids do improve the uterine artery blood flow velocity, another important factor in the etiopathogenesis of recurrent implantation failure, which is a very dreaded complication to all those expertise practicing in the field of assisted conception. So the mean uterine artery pulsatility index values by 16%, a significant reduction, which has a favorable impact as far as uterine perfusion. So to sum up, antioxidants in PCOS, it improves ovulation rates, improves menstrual irregularities, improves endometrial thickness, increases clinical pregnancy rates, insulin resistance, and the lipid profile. In ART, it improves the rate of morphologically good quality embryos, blastocysts, improving the total implantation rates, and thereby the live birth rates. So any role of antioxidants during pregnancy, it has been documented that limited antioxidant micronutrients would result in an excessive oxidative stress within both the placental circulations and the maternal circulations, which might lead to a poor pregnancy outcome. The role of omega-3 has been mentioned in a number of studies, and if we want to come up with meaningful conclusions, let's get back to evidence. The Cochrane. So searching for evidence in August 2018, exploring 70 RCTs with almost 20,000 women, a group of women who received omega-3 versus others who did not use omega-3 using a placebo. So the incidence of preterm birth and very preterm birth, a preterm birth is prior to 37 weeks and a very preterm birth is prior to 34 weeks, was significantly reduced in women receiving omega-3 compared to others. There were also fewer babies with low birth weight. However, a very interesting note and an alarming one too is that the use of omega-3 probably increases the incidence of pregnancies continuing beyond 42 weeks or a post-datism. So omega-3 and pregnancy. The preponderance of data here relates omega-3 fatty acid intake being important for fetal brain development and the deprivation of which during pregnancy is associated with impaired developmental and behavioral scores. What about the role of zinc? A frequently talked about element. The role of zinc is not only in immunity as an immunity booster, as evidenced by a very multitude of literature in immunology, nutrients, Journal of Medical Virology, and lastly, last but not least, in the Lancet last year, which came up with a very favorable impact of zinc having a vital role to support the immune system by inhibiting viral multiplication, improving lysosomal function, reducing inflammatory cytokines, and thereby minimizing disease complications. So, zinc consumption during pregnancy increases the maternal serum zinc level and neonatal weight. The neonatal weight has a positive correlation to maternal serum zinc. Again, quite an important conclusion. Here again, a systematic review exploring the role of zinc deficiency during pregnancy and lactation has come up with very interesting results. So deficiency has been associated with a low birth weight, fetal growth restriction, impaired cognitive function, decreased production of milk, pregnancy-induced hypertension, pre-labor rupture of membranes, placental abruption, prolonged labor, hemorrhage, infections, congenital anomalies, increased neonatal morbidity and mortality, and poor neurobehavioral development, almost all of the high-risk pregnancy complications. And the role of micronutrients in the periconceptional years. We all teach our students that folic acid, perhaps antioxidants should be started well before getting pregnant in the preconceptional area. And there again, this wonderful manuscript published in the Human Reproduction Update, a very prestigious journal, a little bit old, but still very valuable, came up with the important role of micronutrients in the periconceptional period. So antioxidants like zinc, selenium, vitamin C affects fertility, conception, implantation, fetal organogenesis, and last but not least, placentation with all the placenta-mediated disorders. So we move on to the concept of fetal programming. And this has been improvised for decades, that stress is transmitted to the placenta with a variety of influences, nutritional, drug-induced, like smoking, many others, do influence the risk of adult diseases, increase the risk of pregnancy complications, both mother and baby, and most importantly, are transgenerational. That is, they are transmitted across the coming generations. So we might as well tell women, pregnant women or moms to be, that they are held accountable for the whole future of not only their baby, but generations to come. بأمر الله طبعا. So antioxidants, where do they fit in our current puzzles? They do fit a lot, but as you put a picture, you end up searching for another. So it's a never-ending story. So the role of antioxidants before getting pregnant, during pregnancy, and after pregnancy cannot be overemphasized, because it's important before getting pregnant, preconceptionally, while getting pregnant for the mother and baby, and last but not least, for supporting lactation. An ideal antioxidant should look like having an optimum concentration in all tissues of the body with a multi-component, and it reactivates endogenous defense mechanisms. And one of the good examples here is oxy-free for having minerals and vitamins, omega-3, alpha-lipoic acid, and last but not least is a powerful herbal antioxidants. Now moving on to from theory to practice, applying evidence-based medicine in practice. Is it easy? Is it difficult? Or is it impossible? So the systematic reviews are on the top of the scale, as we all know, and the editorials of the expert opinions lie at the very base. With a grade A recommendation, as I've mentioned in my previous presentation, is a very strong one on which endocrinologists and obstetricians, gynecologists can rely with considerable satisfaction that this is the best available cutting-edge information. So these are the levels of evidence and the grades of recommendation, which we all know, and we all opt for a grade A recommendation and a 1A level of evidence. In theory, there is no difference between theory and practice, but in practice, there is, in fact, a lot of difference. So I would like to reiterate what I've mentioned in the previous presentation, that half of our medical knowledge is not true problem knowing, which half we might be seeing only the tip of the iceberg. And what we are trying to do right now and for the decades to come is to have a clearer image, or to have a focused image. The truth lies somewhere in the middle, but not in the eccentricities. So what we are having today is the available cutting-edge data, the available tools, one of which is ultrasound, and the reproductive specialist. And I would like to emphasize that our role in reproductive research is a very important one. We should make maximal use of our personal experience, clinical skills, because evidence-based medicine applies to a sample population, not the entire population, and therefore it provides evidence, not all evidence, some proof, but not the only proof. So here again, the magic is in the magician and not in the wand. So are all reproductive secrets of antioxidants being unraveled? And the very unhappy answer is no. So I would like to put again this black slide saying that we are far from reaching a satisfaction as far as research strategies, recommendations, and we have a long way to go, and it's very easy to miss a step in darkness. So Professor Hassan, ladies and gentlemen, dear colleagues, I would like to reiterate the take-home messages about the oxidative stress and antioxidants utilizing the word antioxidant. It's all important because we are talking about a process that is crucial for the function of all bodily cells. In this particular issue, it's the cells related to reproduction. Yes, it is a normal process. It happens in each and every human cell, but in a balanced way. It occurs in almost all tissues of the entire body, not just the reproductive tissue elements. The problem comes when there is an imbalance between pro-oxidants and antioxidants, and where this happens, you end up having an oxidative stress. An oxidative stress adversely affects the immune system and all immune-related diseases. So you may end up with having a multitude of diseases, not only in the reproductive tract, but in actually every part of the human body. Now, what happens if you use antioxidants? You might achieve a natural pregnancy and a better pregnancy outcome using assisted conception or the IVF-ICSI procedures. You end up having a normal pregnancy outcome for both mother and baby. And last but not least, this is my final word, that antioxidants have truly reproductive benefits. We should be using maximally the advantages of such drugs given in a small dose, but might have a major influence on reproductive functions. Thank you very much indeed.
Thank you, Professor Ahmad, for this concise presentation. You have provided us a lot of effort today. Thank you very much for your effort with us today. Our next lecturer is our eminent lecturer, actually Prof.Dr. Hisham Elgammal from Alexandria University. Now we are waiting for him.
Thank you, Dr. Hassan, for this nice introduction. Thank you, Dr. Ahmad, for the very nice presentations that you have provided us and all the information that you have given us today. And I'd like to thank everyone, especially Dr. Hassan, for inviting me to this very prestigious webinar, and for DevartLab for organizing this. So my talk today would be ultrasound interventions in obstetrics. الموضوع عشان to start talking about this topic, we need to understand the idea from prenatal diagnosis. So it is a science of identifying malformations, disruptions, chromosomal abnormalities, and other genetic syndromes in the fetus. والgoal بتاع prenatal diagnosis is to provide accurate information regarding short and long-term prognosis, recurrence risk, and potential therapy, and thereby improve counseling and optimize outcomes. وعشان كده هو الidea comes in the prenatal diagnosis is two major parts. Part is screening and part is diagnosis. With screening, we have the non-invasive procedures to screen the fetus with. Those will include the ultrasound, including the first trimester, second trimester screening. For first trimester screening, we utilize the nasal bone, the nuchal translucency, and so on. We can also utilize anatomical examination for first trimester لغاية 14 أسبوع, and then moving on into the second trimester. في حاجة non-invasive تانية زي maternal biochemical markers, بالدبل marker test, triple marker test, and quadruple test. ودلوقتي الإيرا بتاعت cell-free fetal DNA has been introduced in the last decade and has taken a lot of momentum for diagnosing, especially for screening, and then later on diagnosing with other invasive procedures. For diagnosis, we use invasive procedures in order to identify the problem that is there, and through it we can use what is called different invasive procedures in obstetrics, including the first trimester amniocentesis that has been abandoned. بس بعد كده في chorionic villus sampling. We have the second trimester amniocentesis, fetal blood sampling, and fetal tissue biopsy. So all this comes into the idea of prenatal diagnosis using invasive procedures. وبعد كده هو في الكونسبت بتاع prenatal therapy in which we try to perform again more invasive procedures to the fetus in order to treat these conditions. So talking about the different interventions that we use as regards invasive interventions, في amniocentesis, and this is either diagnostic or therapeutic. With therapeutic احنا كلنا عارفينه في ال cases of amnioreduction in cases of polyhydramnios. The chorionic villus sampling, we have the umbilical cord fetal blood sampling, وده ممكن نستخدمه diagnostic، ممكن نستخدمه treatment of cases of fetal anemia، أو ممكن نستخدمه in the administration of treatments in certain conditions زي cases of fetal arrhythmia and so on. Treatment of complications of monochorionic twin pregnancy, treatment of problems with the lung، وهنتكلم على يعني shortly we'll talk about these abnormalities. Lower urinary tract obstruction and heart catheterization has been taken a lot of impact في last couple of years. وفي selective fetal reduction. طبعا انا كنت مطلوب مني ان انا اتكلم على كله في نص ساعه، فمش هنقدر ان احنا go into all the details، بس we'll talk about the most commonly used procedures and the most known and the most useful for our community، عشان برضو بنتكلم في حاجات more or less realistic احنا بنقدر نعمل ايه وما بنقدرش نعمل ايه. So if we start with the most importantly used methods for prenatal diagnosis, including the chorionic villus sampling, the amniocentesis, umbilical cord sampling, والfetal tissue biopsy. هنبدأ أول حاجة indications for these different procedures. When do we need to take a sample from the baby in order to genetically diagnose that there is something wrong with the baby? فأول indication is in pregnancies with high risk of chromosomal abnormalities. عشان understand this point, what is a high risk of chromosomal abnormality, ممكن في الأول نعمل non-invasive procedures زي double marker testing، بيقيس levels of Papa A، بيقيس levels of free beta HCG، وبيطلع levels in relation to gestational age. We identify if there is a risk for development of chromosomal abnormalities or not. ممكن نستخدم ال combined test using a double marker test, the two markers with ultrasound findings في الفيرست ترايمستر زي increased nuchal translucency. ممكن نستخدم combined test plus اللي هو ممكن نستخدم معاه nasal bone, ductus venosus and tricuspid regurg as all markers for chromosomal abnormalities. ممكن نستخدم with these we can get a detective rate of 90% with a false positive rate of 5%. مع combined test plus when we add more criteria ممكن detect detection rate of 97% with a false positive of 3%. وفي cell-free fetal DNA, which includes ان انت if we took a blood sample from any one of us هنلاقي free fetal DNA that is roaming into the blood, and this happens from the apoptosis and necrosis of cells all over our body. In a patient, a female patient that is pregnant, she has extra tissue اللي هو placenta, and this placenta undergoes apoptosis and necrosis as well, some cells. والcells ديت بتطلع DNA، والDNA ده بيبقى fetal DNA. So in the maternal blood لو أخذنا sample we will identify maternal DNA and fetal DNA, and from the fetal DNA we can identify if there is something wrong with the baby ولا لا. كل دول are considered to be screening tests. Okay, so if you did a screening test for early pregnancy at 11 to 13 weeks using either a double marker, for example ده cascade نستخدمه. We use the double marker test مع nuchal translucency. If the patient is high risk, we go into an invasive test زي chorionic villus sampling or amniocentesis and so on. If the patient is low risk, we do not do nothing and we encourage the patient to perform a second trimester screening. On the other hand, if she has a moderate risk, ممكن نعمل cell-free fetal DNA as an extra step. Although it is a little bit expensive. ولو cell-free fetal DNA طلع positive, we go into invasive testing because it is very, very important to understand that cell-free fetal DNA testing for the fetus is a screening test. It is not a diagnostic test, although it is very highly efficient, very high detection rate, very low positive, false positives. إنما still it is a screening test. If it is positive, we go to invasive. If it is negative, we do nothing. يبقى ده كان what is called in pregnancies with high risk of chromosomal abnormalities. Other indication for invasive prenatal diagnosis, any structural anomaly detected on ultrasound anatomical screening, either وانت بتعمل في first trimester or going into the second trimester scan, a history of a child with a known genetic disorder, a parent known carrier for a genetic disorder or a chromosomal abnormality, and in the search of some metabolic syndromes or inborn errors of metabolism. طيب, take care برضو when you stick a needle inside the uterus and pick up samples. What do you intend to do with this sample? يعني ايه what do you intend to do with this sample? What can the lab do with this sample? الجينetics هيعملوا ايه بالموضوع ده؟ They can do conventional karyotyping اللي هو بيحط السيلز into culture وبعد كده هو بعد ما بيحصل mitotic figures they take the chromosomes, we arrange the chromosomes and identify the numbers of chromosomes. ممكن يعمل single gene sequencing if the specific gene is identified and known. بس في حاجات تانية بتتعمل. المايكرو اري اناليسيس ده اللي هو بيديتكت المايكرو ديليشن المايكرو دوبليكيشن. في حاجه اسمها الهول اكسوم سيكونسينج بيidentiفy any abnormality detected in the DNA وفي examination of some metabolic syndromes. خد بالك ان في مصر مش كل حاجه بتتعمل. We can do conventional karyotyping and this is the maximum. Sometimes single gene sequencing, but microarray analysis, whole exome sequencing, and identification of some metabolic disorders is limited to a very limited number of labs. فمهم جدا تبقى expecting ايه اللي متوقع تطلعه من السامبل اللي هتبعتها للمعمل. تبقى عارف ايه المعمل ناوي يعمل ايه في السامبل دي، conventional karyotyping بس ولا عنده capabilities ان هو identify micro بالمايكرو array analysis او whole exome sequencing. ليه بقول الكلام ده؟ عشان about 30 to 40% of anomalies ماشي ممكن تبقى detected by conventional karyotyping، انما الباقي كله مش هيبقى detected بالconventional karyotyping. فممكن تلاقي في anomaly في البيبي وانت شايف anomaly بالالتراساوند، بعد كده تبعت تعمل amniocentesis والكاريوتايبنج يرجع لك completely normal، والمشكله مش هتبقى كده، هتبقى micro deletions or micro duplications. Chorionic villus sampling لو بدأنا نتكلم فيه it is a prenatal test to detect chromosomal or genetic disorder that is performed at an early stage of pregnancy, can be performed at any time during pregnancy, and it involves retrieval and examination of tissues from the chorionic villi, and it is also called chorionic villus biopsy. The idea behind the chorionic villus sampling get in the amniocentesis, this is the best method. هنتكلم عليها ليه هي the best method. Amniocentesis gives its results عند 17 ل 18 اسبوع because to perform proper amniocentesis بتعملها عند الاسبوع من بعد الاسبوع ال 15، وعشان السيلز تاخد وقت ان يحصل لها culture والريزلتس ترجع لك حوالي 10 ايام. ف 17 to 18 weeks you get a decision. فالchorionic villus sampling can be done as early as 11 weeks والresults ممكن تطلع within 12 weeks. ف if we have a technique that could be performed safely in the first trimester, early in the first trimester, it could reduce the psychological stress of awaiting results until pregnancy becomes later on, where it allows a safer method if termination of pregnancy is indicated. وده عليه علامات استفهام طبعا، احنا هنترمينيت ايه او مش هنترمينيت ايه. ف this is the idea why we perform chorionic villus sampling, because it gives me an earlier diagnosis. كان الهيستوري chorionic villus sampling it was blindly tried في 1968. بعد كده في 1975 it was successful in China وكانوا برضه blindly utilizing it، وكانوا بيعملوها عشان identify الميل من الفيميل في ايام ما كان في السنجل child policy. بعد كده هو من الانترودكشن اوف ultrasound في 1980s الترانس سيرفايكال كان الاول، بعد كده هو الترانس ابدومينال، وبعد كده هو اتستوبت شويه المومنتم بتاعتها عشان الامنيوسنتيسيس became available, it became safer, it became easier to perform. بعد كده هو it was reintroduced again لما التكنولوجي بدأت تتحسن especially بتاعت الالتراساوند and the different routes different complications were identified. So when do we need chorionic villus sampling؟ نفس الانديكيشنز بتاعت اي حاله prenatal invasive diagnosis. إنما specific for chorionic villus sampling, it provides early diagnosis in cases of early pregnancy. وبرضه it is logic لو if we have an oligohydramnios or an anhydramnios in which there is no liquor, we can perform chorionic villus sampling for sampling something from the baby. Empty to be performed, when to perform it, usually can be performed as early as 8 weeks, although the recommendations من 2010 في RCOG, which has been updated in 2017. Again, the International Society of Ultrasound and Obstetrics and Gynecology in 2016 has given guidelines. It should not be performed before 10 completed weeks. So 11 weeks is better because this is associated with a higher possibility of mandibular defects, higher possibility of limb defects. And before 11 weeks, it is a little bit technically difficult to perform. أهم حاجة, before any invasive procedure, you have to take a written consent from the patient, and you have to describe the procedure, you have to describe the risks related to the procedure, complications, side effects, complications اللي ممكن تحصل. The accuracy of the lab test should be examined, explained, what results are possible. The culture failure is very, very important because the cells that we take, the lab perform cultures on them. When cells are dead, the culture will not occur. For culture failure is important. Accuracy and possible ambiguity of results and expected time for reaching a diagnosis. زي ما قلنا, it takes time for this to happen. How to perform chorionic villus sampling? عندنا 3 routes: trans-abdominal route, trans-cervical route, and the trans-vaginal route. Trans-cervical كان أول حاجة استخدم. الأول you perform an ultrasound examination identifying the uterus, identifying the fetus, the number of fetuses, the site of the placenta. You detect the cervix. You identify then by speculum examination the cervix. You clean the vagina by an antiseptic iodine solution. Indicate that the cervix is very nicely clean. There is no infection in the vagina. There is no infection in the cervix. وممكن بعد كده هو أبدأ البروسيجر. بستخدم 2 types من البروسيجرز في cervical chorionic villus sampling, either the aspiration technique or the biopsy using a forceps technique. Aspiration technique في cannula بستلات 16 gauge cannula, it is a thick cannula, and the distal end بتاع الكانيولا دي زي ما انتم شايفين بيبقى curved to allow guidance. allow guidance بتاع الكانيولا into the cervix, inserted until it reaches the tip of the placenta or the edge of the placenta. وكل ده لازم يبقى ultrasound guided through trans-abdominal ultrasound. Once you reach the tip of the placenta, the edge of the placenta, as you can see, and it's nicely seen for either anterior or posterior placentas, you remove the stellate, provide a syringe وبسحب يا اما بالفاكيوم اسبريتور اللي مش محتاج حد تاني ان هو يبقى بيسحب السن، او انا اسحبه يعني انا بسحبه بنفسي بالاسبريتور ده، او بستخدم حد تاني ان هو اللي يسحب السن وانا بجايد الكانيولا، هو اللي يسحب يعني السامبل وانا بجايد الكانيولا. طبعا I could use the Valcellum to provide counter traction, and it is considered to be the most popular method as regards the transcervical route. ممكن استخدم البيوبسي فورسبس في 2 types of forceps. في الستريت فورسبس اللي هو الكروكودايل اللي احنا كلنا عارفينه with a very small diameter 2 meter، او في السنيك فورسبس اللي هو بيبقى عنده tilted tip شويه او curved tip to allow insertion into a an abdominal or a posterior placenta, anterior or a posterior placenta. وطبعا ممكن املى البلادر شويه عشان يعمل لي شويه tilting of الانتيفيرتد uterus عشان to make the placenta in the way. برضه بقى insert forceps inside the cervix until I reach the placenta, and then I pinch some of the tissue and see what tissue I have pinched out over the culture media and provide this to the lab for diagnosis. The transvaginal route, the تاني route, بيستخدم عادة في cases in which we have a retroverted uterus with a posterior placenta. It becomes a little bit difficult either to use the transcervical or to use the trans-abdominal route. Using a 20 gauge needle, ممكن استخدم 1 needle approach أو 2 needle approach. 2 needle approach يعني بدخل thick needle into to pierce the vagina and then pierce the uterus, and then introduce a 3rd needle to pierce the placenta. وزي ما قلنا it is used with retroverted posterior placentas. في most of the people that use or perform ARTs are very familiar with a transvaginal approach with a needle guide for embryo transfer for قصدي ovum pickup. فبيحبوا يستخدموا الميثود ديت على اساس ان هي شبه قوي الميثود بتاعه الاوفم pickup. بس the problem with this is a higher rate of infection has been reported with transvaginal chorionic villus sampling. Transabdominal route, this is again one of the most popular. ممكن استخدم a freehand approach or a needle guided technique. Needle guide technique بيبقى فيه needle guide موجود جنب لازق في الترانسديوسر. ده بيساعد شوية المبتدئ لسه في الأول عشان guide where the needle is going. وفي new needle guides بعد ما بحط النيدل ممكن dislodge the needle guide بحيث ان my hand becomes free in moving the needle and my transducer becomes free in mobilizing it over the abdomen. For transabdominal, I use sterile aseptic technique. Wash the abdomen of the patient with aseptic solution, antiseptic solution, identify the uterus, the location of the placenta, the viability of the fetus, الحاجات الروتين, and then I introduce the needle. I could use a 17 to a 20 gauge needle, or I could use the double needle technique using a thicker needle and a thinner inner needle. Once I introduce the needle with an ultrasound guide, the very important point is to introduce it parallel to the chorionic plate. لازم ابقى parallel الانترودكشن بالنيدل لازم تبقى داخله زي ما انتم شايفين هنا اهوت parallel to the chorionic plate. عشان النيدلز هنا اهوت are very thin in comparison to aspirated needle في aspirated cannula في trans cervical approach. فبستخدم movement وانا بشتغل ان انا شد البلانجر زي ما انتم شايفين كده اهوت and I start moving the needle to and fro about 10 times within the placenta. الموفمنت ده بيقطع chorionic villi صغيره والchorionic villi ديت بتبقى aspirated. Continuously while performing the aspiration I perform this to and fro movement ولازم كل ده يبقى as parallel as possible to the chorionic plate. كل ده بيتسحب في ميديا كلتشر ميديا بتبقى ريدي معايا جايه من المعمل وبعد كده هوت I make sure ان انا طلعت adequate amount of chorionic villi تقريبا 5 ملغ سوري. والبوينت الثانيه ان بيبقى معاها ديسيديوا والمعمل بعد كده هو بيظبط ان هو يشيل الديسيديوا from the contamination of this decidua from the chorionic villi. In cases of multiple pregnancies, chorionic villus sampling becomes a little bit difficult. You have to use separate needles and syringes for each sampling. You have to collect samples as close to cord insertion as possible. Of course, it becomes very easy if two placentas are separate with two different placental locations. Now, one placental location becomes a little bit difficult. Avoid collecting samples from an area of a dividing membrane عشان بيبقى قريبين الاثنين chorionic plates لبعض. Avoid more than one passage in the same part of the chorion. Use a transabdominal rather than a transcervical approach where expertise is very, very important in order to label the fetuses, fetus 1 and fetus 2 with its different placentas عشان لما تيجي results نبقى عارفين أنهي fetus affected عن التاني. Complications of chorionic villus sampling include bleeding, which happen about less than 1% of cases, from 1 to 4% of cases. Infection is very rare as long as you take very proper antiseptic techniques, although sometimes it happens, and when it happens, you have to evacuate the uterus immediately. The fetal loss is a little bit low. Risk of miscarriage is associated with 0.5%. 60% of pregnancies within the first 4 weeks after the procedure if miscarriage will happen. But there is no difference in loss rate was noted between 1 and 2 needle insertion. Maximum for كل interventions, 2 needles is the maximum. You should not go more than 2 times in order to prevent more complications. Fetal limb defects, زي ما قلنا, it happened before 10 weeks. So always perform, before 9 weeks actually, always perform chorionic villus sampling after 11 weeks. This is the best time, and we can perform it until full term, especially in cases in which we have oligo and hydramnios in order to get some fetal tissue. Moving on into the second procedure اللي هي الامniocentesis. الامniocentesis refers to transabdominal aspiration of amniotic fluid from the uterine cavity. كان في الأول introduced for polyhydramnios decompression وده كان في ال 1880s. Later on في ال 1950s كان introduced for examination of fetal anemia وكان في curves معمولة for bilirubin examination in these cases in which babies developed RH incompatibilities. Whereby in 1966 it became more evident for karyotyping and genetic diagnosis, and it took over عن الchorionic villus sampling. وعشان كده chorionic villus sampling قل شوية وبعد كده راجع تاني في الآونة الأخيرة. إمتى بيتعمل؟ When is the timing for amniocentesis? It is best performed within the second trimester. Starting from more than 14 weeks, better at 15 to 18 weeks. This is the best time to perform as an amniocentesis. If we went into the first trimester, we have a lot of problems. The first, زي ما انتم شايفين على الصورة اللي على الشمال, الامniotic membrane is still separate from the chorionic plate by what is called the extra-embryonic coelomic cavity. So the extra-embryonic coelomic cavity has not been fully obliterated. ففي possibility of indenting the amniotic membrane وانا داخل, with this indentation could be a cause of failure. تاني حاجة, the amount of amniotic membrane is very small, which could be associated with injury of the fetus, causing fetal loss or talipes equinovarus in a lot of cases. The third trimester, المشكلة بتاعته, it is very easy to be performed, of course, 20 weeks, but going after 28 weeks. But the problem is the ratio between viable and non-viable cells in the amniotic fluid becomes much higher. فبتلاقي a lot of non-viable cells في third trimester. عشان كده هو the possibility of culture failure becomes high في third trimester, and that is why second trimester is considered to be the best time to perform it. ازاي استخدمه؟ زي ال chorionic villus sampling transabdominally, either utilizing the freehand technique or the needle guided technique. انا بفضل دايما الفري هاند تكنيك عشان الموفمنت في النيدل جايدد تكنيك بتحكم ان once الترانسديوسر جبته على حته وحطيت النيدل, you cannot move the transducer. If you move the transducer, the needle will move. انما الفري هاند بتallow ان there is free hand movement between the transducer and the needle completely separate. Again, you have to prepare the patient in a completely aseptic technique, use a sterile gel, or use a cover for the probe, and all these procedures to prevent the infection from happening. أول حاجة identify again the fetus viability, check for anomalies. We are now passing into the 15-week or 16 weeks, and we can see a lot of the anatomy in the baby just to document if there is something wrong with the baby or not. And then identify the position of the placenta. وزي ما انتم شايفين in this video, the indentation that is performed by the hand to make sure where will the needle pass. And to identify where the placenta is, whether it is anterior, posterior, fundal, lateral, and so on, عشان we need to prevent insertion inside the placenta. We use a 20 to 22 gauge needle, a very thin needle. Length of the needle will depend upon the obesity of the patient and the thickness of the anterior abdominal wall. Again, identifying where to introduce, and we can either use برضو aspirator, a vacuum aspirator that helps the syringe pulling, أو I can use it on my own. بس ده محتاج 2 operators, واحد يمسك البروب مثلا, واحد تاني يبقى ماسك النيدل, أنا أبقى ماسك النيدل وبسحب بالبلانجر. النيدل insertion has 4 stages. أول حاجة الabdominal skin puncture. Introduction of the needle should be 45 to the longitudinal axis of the mother, and should be about 90 degrees من البروب to allow proper visualization of the probe. It is very important, زي انتم شايفين على الناحية اليمين, ان انا avoid the bowel perforation. Once a bowel is perforated, ممكن ياخد كل bacterial content of the bowel and introduce it into the amniotic fluid. It is very, very important ان انا I should not pierce the bowel. خلي بالي ان انا ببيرس في الفيرست ستيب الابدومن, السكن, الماسل, لغايه ما اوصل لليوترس. بعد كده هو ابدا puncture. Second stage is to puncture the uterus, and while puncturing the uterus it becomes very painful for the patient. I should advise the patient not to move, not to take a deep breath, عشان كل ده allow movement of the needle too much. ثالث حاجة, entering in the amniotic cavity. Once I pierce the wall of the uterus, I should jot the needle rapidly inside the amniotic cavity. ما دخلش بقى needle very slowly بعد كده هوت. Once I reach the uterine wall and I pierce the uterine wall, I introduce the needle very rapidly in order to pierce the amniotic membrane and prevent indenting of the amniotic membrane. زي ما انتم شايفين على الصورة on the left side, the amniotic membrane could be dented وانا بدخل. هاخده من الكوريونيك بليت واروح مزقه معايا, and this will cause failure of aspirating any fluid. So it is very important to jot it once I reach the amniotic membrane. وبعد كده هو advancement is I push it into the pocket of amniotic fluid that should of course be free of fetus and free of cord, with a very thick, very wide pocket to gather as much fluid as possible. أول 1 millimeter I usually discard, and then I should aspirate about 15 to 20 millimeters, 20 to 30 millimeters, and depending upon the textbook you are reading from, but so about 20 millimeters is more than enough. خلي بالك, we usually do not go transplacental. We try to avoid transplacental as possible, but sometimes it is unavoidable when the placenta is anterior. If transplacental approach is the one that you would use, you will see the thinnest part in the placenta to push the needle in. Avoid areas of cord insertion عشان ده بيبقى فيها vessels كتيرة. ممكن تحط الدوبلر to make sure that there is no major vessels that will be introduced while passing through the placenta. كل ده ممكن يعمل هيماتومز, واللي بيعمل هيماتومز ممكن يبقى associated with failure, loss of the baby afterwards. So transplacental approach should be avoided as much as possible, but sometimes it is unavoidable. Take care in uterine contractions could happen. We all see uterine contractions during our examination, where once you introduce the needle inside the uterine contraction, you will not be able to introduce the needle more inside the baby. Inside the amniotic membrane becomes very difficult and it becomes very tender for the patient. فأحسن إن أنت تمنع أو ما تشتغلش في الوقت اللي بيبقى فيه uterine contractions. في العادي أنا ببص على الحالة, and if I see a uterine contraction, I tell the patient to go out and come back after maybe half an hour until the uterine contraction has been lost, and then I could introduce the amniocentesis. Maximum 2 attempts, never go 3 attempts. Once you go 3 attempts, it becomes more or less a failure, and later on could cause a lot of complications. Complications, هو lower abdominal discomfort usually happens for about 48 hours after the procedure. Amnionitis, this is very, very rare, although it could happen, especially if you pierce the bowel. هتاخد أي content موجودة, بكتيريا موجودة وتدخلها جوه الامنيوتيك membrane. فلازم to be very, very careful, ولازم تبقى واخد as much aseptic technique as possible. Amniotic fluid leakage could happen, or vaginal bleeding could happen in about 2 to 3% of cases. Where in early experience with amniocentesis كان في puncture of the fetus sometimes happened لما كان الموضوع لسه مش واضح قوي وإيه اللي بيتعمل, sometimes it used to happen blindly. With piercing of the baby, a lot of complications used to happen, but sometimes it happens. يعني piercing the baby happens and nothing happens to the baby. بيتولد البيبي بيبقى كويس ما فيهوش حاجة, but you should avoid piercing the baby as much as possible. And of course, you should avoid this by continuous use of ultrasound to guide the needle, and this minimizes the needle puncture to the baby as much as possible. We're in the hands of an experienced sonographer or an experienced operator. الموضوع بيبقى very, very rare to pierce the baby. In twin pregnancy, it is again a little bit difficult, but you can use the dye method. كانت بتبقى used في الأول. indigo carmine dye can be يستخدم. So you insert the needle and then you push some dye inside the amniotic sac of the first baby, and then you introduce and then you introduce a needle into the other sac, and then you aspirate. لو طلع معاك fluid يبقى معنى كده هو ان you are in the same sac. اللي هو لو طلع معاك color يعني, and لو no color came out, this means that you are in the second sac. But this method has not been popular now. في دلوقتي single puncture technique in which identify a separating membrane زي ما انتم شايفين هنا اهوت, and you introduce the needle very close to this separating membrane. في الأول you introduce the needle into the first sac, you aspirate fluid, and then you introduce the needle furthermore, piercing the intertwin membrane and going into the second sac under ultrasound guidance. And this could be done بعد كده اهوت, you aspirate some fluid and you throw it, and then you aspirate new fluid for the second sac. One needle or two needle approach, يعني either you use the same needle من الأول لغاية الآخر, or you use a thick needle في الأول, introduce it into the first sac, then introduce a smaller needle for the first sac, and then pierce the amniotic, the intertwin membrane, and introduce a second needle for the other sac. ده الطريقة اللي بتستخدم for twin pregnancy, although again, twin pregnancy for amniocentesis is very difficult, and you should برضو label the babies, because if you aspirate from fluid, you have to label which baby you have aspirated for the results to be comparable. A very new meta-analysis for the risks of amniocentesis and chorionic villus sampling. اللي بيشتغل amniocentesis أو chorionic villus sampling بيمضي consents for pregnancy loss that is about 1 to 2%, and that was based on a randomized controlled trial for 1986. But this is not the case in new evidence. اللي بنتكلم very, very low levels of miscarriage, 0.1% for amniocentesis and 0.2% for chorionic villus sampling. There is very new evidence coming out about this safety of the procedures. وكل ده كان برضه يعني ايه جذب وشد ما بين الناس اللي عايزين يعملوا invasive اكتر والناس اللي عايزين يشتغلوا cell free fetal DNA اكتر, وبيقول لك cell free fetal DNA ما هو حلو اهو كويس ما فيهوش اي مشكله, ملوش لازمه الريسك اوف chorionic villus sampling والامنيوسنتيسيس which is 1%, بس كل الميتا اناليسيز اللي طالعه بتقول حتى الريسك ده is very low, so it is okay to perform invasive techniques if you want to perform it. Moving on لثالث حاجة مهمة هو الumbilical cord fetal blood sampling, وده started في 83 as an alternative method for aspirating blood from the umbilical cord عن الفيتوسكوب اللي كانت الميثود اللي بتستخدم قبل كده هوت. وكان الايديا من aspiration of fetal blood ان it provides rapid karyotyping. بس nowadays مع الامنيوسنتيسيس والchorionic villus sampling and the new technologies that can provide rapid results as well, fetal blood sampling بقى limited to cases of fetal anemia في treatment mainly rather than diagnosis حتى, و for cases of thrombocytopenia and some for diagnosis of some cases of fetal infections. وزي ما قلنا it can be used for treatment cases of fetal anemia and cases of some arrhythmias in which you need to provide some treatment for the baby. فيها by identify the position of the placenta. An anterior placenta is much better than the posterior placenta. Posterior placenta is very difficult. You identify the position of the umbilical cord insertion because this is the best area of aspiration or of intrauterine transfusion. اللي هي cord insertion into the placenta. عشان this is a stable area of the cord that doesn't move مع movement of the baby and it is very stable. An anterior placenta much easier and much accessible than the posterior placenta. لو هتعملها posterior placenta you need a very long needle, فلازم تبقى واخد into consideration a long needle that is about 20 centimeters or more long. خد بالك مع long needles ان هو the needle bends easier وانت بتدخلها وبتمانيبيوليت شويه, فهتلاقي النيدل بتبند وممكن اساسا the procedure fails by this bending. Insert it into the umbilical vein, not the umbilical artery, because this causes less bleeding and less hematoma. So the umbilical vein is the one that we are targeting. Once you reach it, برضو you go in, you reach the uterus, you pinch rapidly inside the uterus, then you start advancing it until you reach the umbilical cord. And once you reach the umbilical cord, again, another jot in order to pierce it easily and nicely, not only to push it. ففي الumbilical cord sampling بنستخدم مرتين الزقة دي. المرة الأولانية piercing the amniotic membrane, والمرة الثانية when we reach the umbilical cord to go inside the cord rather than just pushing the cord to the side. Then you start to inject, and it depends if you are aspirating for diagnosis or you are injecting blood for cases of fetal anemia. ولو injecting blood it depends the amount of blood. لازم تستخدم O negative blood، تستخدم الاماونت بيبقى about 10 millimeters every week after 20 weeks. فلو عندك مثلا baby 29 weeks then you will inject you will transfuse about 90 milliliters and so on. It is a little bit difficult to inject blood very thick blood، فلازم تبوش جامد ويبقى معاك حد بقى مجهز السيتنج. البلاد داخل على 3 way وبعد كده في IV connector داخل على النيدل. يعني فيها شوية logistics بس it could be done and it is very useful in cases of fetal anemia. ممكن انا اعمل الكلام ده في البيبي ان انا بعمل انترا هيباتيك في الانترا فيتال through the hepatic vein اللي هو الانسيرشن بعد ما الامبلايكال فين يخش inside the abdomen of the baby. It becomes easy، بس ساعتها لازم stop البيبي from moving بان انا اديله muscle relaxant. وساعات لما الموضوع بيبقى very early in pregnancy وعايز اعمل transfusion ممكن اخش انترا كاردياك في الهارت بتاع البيبي، بس again I should stop the baby from moving by giving it muscle relaxant. Fetal loss is identified as that of the baby within 14 days of the procedure, and it is about 1 to 1.3% of the patient. The major cause of fetal loss هو chorioamnionitis, rupture of membranes, puncture site bleeding, and severe bradycardia and thrombosis that could happen to the baby. نقطة بس عايز أقولها، إحنا كده خلصنا الثلاثة ميجر ومش هنتكلم على حاجات تانية كتير، الموضوع هياخد كمان 5 دقايق بس. إن حاجة بس قبل ما نكمل، الأمنيوسنتيسيس والسيلز دي بيتعمل فيها إيه؟ فالأمنيوسايتس اللي موجودة من الأمنيوسنتيسيس دي بناخدها بتعمل لها كلتشر، وبعد ما يتعمل لها كلتشر يتعمل لها فيتال كاريوتايبنج أو كروموزومال مايكرو أري أناليسيس زي ما قلنا. والأمنيوسايتس دي originating from fetal cells from the fetus itself. Okay. عشان الchorionic villus sampling we are sampling the chorionic villi. From the chorionic villi ممكن ناخد 2 types of cells. السيلز اللي بره خالص اللي هي السيتوتروفوبلاستيك cells. الفايده بتاعت السيتوتروفوبلاستيك cells دول rapidly dividing cells، مش محتاجين ان انا احطهم في culture عشان اطلع منهم chromosomes. دول على طول ممكن ابص تحت الميكروسكوب هلاقي فيها a lot of mitotic figures and I could get results about karyotyping of the baby within 12 to 24 hours. بعد كده هوت ممكن استخدم الميزنكايمال سيلز اللي جوه الكوريونيك فيلاي and اخدهم السيلز دي واحطهم في culture واخليها to grow within 7 to 10 days and then while they are growing and mitotically active اطلع منهم الكروموسومز for karyotyping. مهم ليه الموضوعين دول؟ فمعنى كده هو ان الchorionic villus sampling I could get very rapid results within very short period of time without culturing cells. تمام. ومهم كمان ان هو يفرق لي ما بين الكونتامينيشن اللي ممكن يبقى موجود مع الماتيرنال cells especially زي ما قلنا ممكن ناخد ديسيديو معاها. ليه بقول الكلام ده؟ عشان لازم نتكلم على حاجه اسمها الكونفايند بلاسنتال موسايسيزم. البلاسنتال موسايسيزم از انا فاكرين ان at early development لما كان عندنا blastocyst we have 2 types of cells في البلاستوسيست. You have the inner cell mass وال outer cell mass. And the outer cell mass is the one that is responsible for development of the placenta. The inner cell mass is the one responsible for developing the fetus. النقطة إن during development ممكن موسايسيزم يحصل في one of these types of cells، الانر cell mass أو الأوتر cell mass، أو ممكن يحصل في الاثنين. موسايسيزم يعني one line of cell يديفلوب ويبدأ يريبليكيت بطريقة يبقى فيه ترايسومي أو يبقى فيه aneuploidy rather than normal euploid types of cells. فيبقى عندي 2 cell lines، line في لخبطة في الكروموسومز واللاين الثاني ما فيهوش حاجة. المشكلة إن لو اللخبطه في الكروموسومز حصلت في الاوتر سيل ماس بس مش في الانر سيل ماس، فالبيبي هيبقى كويس بس البلاسينتا هتبقى افكت. فمعنى كده هو لما انا اخد سامبل من البلاسينتا ممكن الاقي فيها ترايسومي موسايسيزم واقول ده البيبي ده ترايسوميك او في مشكله. بس لو جات لك الريزلتس من الكوريونيك فيلاس سامبلينج ان في موسايسيزم في الموضوع you should go and sample the fetus through amniocentesis. فلازم تخش بالامنيوسنتيسيس and confirm اذا كان الموسايسيزم ده موجود كمان في الفيتس ولا لا. عشان في الامنيوسنتيسيس you are sampling amniocytes اللي هي جايه من البيبي اللي هي جايه من الانر سيل ماس. انما في الكوريونيك فيلا sampling you are sampling chorionic villi that is coming from the outer cell mass. هي النقطه دي بس مهمه عشان في الكونفايند بلاسنتا الموسايسيزم لما يبقى في موسايسيزم في البلاسنتا بس ما فيش موسايسيزم في البيبي، فممكن الكوريونيك فيلا sampling يبقى النتيجه بتاعته غلط والبيبي يطلع ما فيهوش حاجه في الاخر. شويه برضه invasive techniques ممكن نعملها بس هنجو through them very rapidly. في حالات congenital adenomatoid malformation of the lung فيها mertomatous lesions, cysts appears in the lung وthe lung develops very abnormally وفي Stocker classification according to measurements of these cysts. ففي عندنا big cyst في smaller cyst and في very small cyst اللي هو المicrocystic type اللي بيبان اكنه solid type. الايديا ان معظم حالات الكونجنتال ادينوماتويد مالفورميشن although البيجر والسمولر تايب منها ممكن undergo growth لغايه 26 اسبوع then usually they plateau and usually they regress وممكن ما تلاقوهمش بعد الولاده. بس مشكله ان في منهم انواع بيكبروا ويفضلوا موجودين ويأثروا على الهيموداينامكس of the baby and this causes increased intrathoracic pressure which could be associated with hydrops fetalis. لو ده حصل في الماكروسيستيك تايب ممكن نستخدم السوماتكس شانتس وبتتحط الشنط inside the cyst زي ما انتم شايفين هنا هو ultrasound guided. I introduce the shunt inside the cyst وبتاخد الفلويد اللي موجود في السيست تطلعه في الامنيوتيك ممبرين او امنيوتيك كافيتي وبتعمل decompression of the cyst as you can see in the video وتلاقي السيست بعد كده هو اتصغرت خالص والهيدروبس ممكن يبقى relieved once hydrops develop in the fetus. فدي ما بتتعملش بس إلا once we have hemodynamic instability of the fetus in cases congenital adenomatoid malformation. في البلمونري sequestration this is part of the lung that has decided ان هي مش هتاخد حاجه من البلمونري circulation وهتاخد part منها من circulation. ف it is part of the lung that has separated from the lung actually and it is now taking its flow from the systemic not the pulmonary circulation. واكتر نوع most common هو الاكسترا لوبر type ويا اما بيبقى above the diaphragm او below the diaphragm. بيبان ازاي في الالتراساوند؟ بيبان as a echogenic shadow within the lung or beside the lung or usually associated زي ما انتم شايفين بهيدروثوركس وبتبقى a very echogenic part of the lung. الايديا كلها ان البلاد سبلاي بتاعها بيجي من الاورتا usually يا اما فاسل من الاورتا في الابدومن او في الثوركس. فالايديا في البلمونري sequestration ان احنا ممكن نخش ultrasound guided لو برضو it started to develop hydrothorax and does not improve بتخش بالالتراساوند بس ده بليزر. فبتخش النيدل اللي فيها الليزر وتوصل للكورد الفاسل that supplies this part of the lung and you start to cauterize this using laser. وده للأسف مش موجود عندنا. أنا بس بقول إن this is one of the techniques that could be used again ultrasound guided. وزي ما أنتم شايفين هو بيحرق دلوقتي ال part which has grown into affecting the hemodynamics of the baby and causing hydrops fetalis. برضه حاجه من الحاجات اللي في اللنج الهيدروثوركس ممكن يبقى unilateral ممكن يبقى bilateral ممكن يبقى isolated او ممكن يبقى associated with a lot of chromosomal abnormalities. المشكله بتاعت الهيدروثوركس ان هو usually لما يبقى isolated ممكن يبوش على الهارت وبرضه يأفكت الهيموداينامكس ويعمل hydrops fetalis. ف most cases of isolated hydrothorax we follow up every 2 weeks. If nothing happens يعني no hydrothorax develop you usually deliver the baby by 38 weeks and you manage this postnatally. Usually اللنجز هتexpand normally بعد الولادة ومش هيحصل أي مشكلة ممكن تأسبريت الفلويد ده بدون أي مشاكل على البيبي. On the other hand, if it is progressive or hydrops starts to develop فلو الجستيشنال age قريب لسه البيبي صغير قصدي ممكن نعمل ثوراكا امنيوتيك شانتنج بالسوماتكس شانت زي اللي شفناها في الكونجنتال ادينوماتويد مالفورميشن او لو البيبي قريب خلاص قرب يتولد فممكن اعمل درينج وانس بس ان انا اعمل زي بلورسنتيسيس اخش بالسن واسحب الاماونت اوف بلورال فلويد وخلاص. اخر حاجه في اللارج بلادر كيسز اوف ميجاسيستس لما بيبقى معاها لور يورينري تراكت اوبستراكشن كان في كلام كتير ان السوماتيك شنت هتنفع اللي هو فازايكو امنيوتيك شانتنج تحطها عشان to relieve البريشر اللي موجود في البلادر وتريليف البريشر اللي موجود في الكدنيز. بس المشكلة في الموضوع ده إن هو the affection of the kidneys has already been done very early in pregnancy with this obstruction, and usually the kidneys are non-functioning anymore. بس ده ممكن ينفع شوية إن هو يحسن chest hypoplasia that happens، وبعد كده البيبي ممكن يتولد ويتعمل له renal transplantation. فده حالات الميجاسيستس والسوماتيك شنت اللي ممكن تتحط as well. To conclude, عندنا prenatal diagnosis و prenatal therapy. There is a lot of invasive techniques that could be used, including most commonly amniocentesis, chorionic villus sampling, and umbilical cord fetal blood sampling, and treatment for lung with treatment for lower urinary tract obstruction. And it is very important to have a good understanding on the different modalities that are present. A learning curve is needed to master each modality so as to reduce morbidities, mortalities associated with each intervention. Know the benefits and limitation of each modality, very, very important. And know the limits of genetic diagnosis, very, very important. Actually available in the community and in the country so as to help you with the decision of which modality you can use. في معامل ما بتشتغلش بالكوريونيك فيلاي خالص، هتشتغل امنيوسنتيسيس بس، فتاخد بالك انت هتبعت العينه بعد ايه لايه. الهدف مش خالص ان احنا نخش بالسن ونسحب حاجه من البيبي، الهدف ان احنا نطلع من ده diagnosis. And counsel patients and take an informed consent is very important as to reduce liability and improve patient understanding of the procedure. Thank you very much and very sorry for exceeding my time.
الحقيقة يعني محاضرة ممتعة جدا دكتور هشام، و as usual يعني انت امتعتنا الحقيقة وبتخلينا يعني نندم ان احنا ما قلنالكش تتكلم زي ما انت عايز طول الليلة يعني.
ربنا يخليك.
الحقيقة يعني حاجة ممتعة، ونندم تاني ان احنا ما جبناكش اسيوط يعني عشان تدي شوية محاضرات نحبسك هناك عندنا. معلش هو حر عليك واحنا اليومين دول مش هنقدر نعمل كده. الله يكرمك، متشكرين خالص يا فندم. انا اولا عندنا بعض الاسئله وهي بسيطه خالص مش تاخد وقت الحقيقه، وبنشكركم اولا، بنشكر الاستاذ دكتور احمد نصر الحقيقه على محاضراته الجميله، وبالطبع الدكتور هشام في غنى عن ان نتكلم تاني. بنشكر طبعا معانا فريق ديفارت لاب الحقيقه على التجهيز والاعداد للمحاضره والاهتمام بها الحقيقه، يعني الحقيقه الناس عملوا تكنولوجي كويس جدا المره دي، والمانجمنت للويبينار الحقيقه كويس قوي. بنشكر برضو شركه مايندري ايجيبت وشركه كايرو ميديكال على السبورت بتاعهم معانا في الشغل وفي كل حاجه. وباقي لنا بس السؤالين الحقيقه. انا لما قلت الاسئله اكتشفت حاجه، ان مفيش غير سؤال واحد بس وهو سؤال عام موجه للدكتور هشام. من عندنا دكتوره بتسال بتقول if cystic hygroma and bone anomalies detected in the fetus about 15 weeks is it an indication for termination؟ يعني هو السؤال مش ريليتد قوي، انما يعني هنشوف. لو تسمح دكتور هشام يقول لنا رايه في الاجابه.
هو الايديا كلها في الترمينيشن اوف pregnancy an ethical issue and a legal issue و religious issue الموضوع الكبير قوي. religious issue ده depending بقى كل واحد وواصل لايه في religious acceptance في الموضوع بتاع termination of pregnancy. فناس بتتكلم ان بعد 40 يوم ما ينفعش، في ناس تانية بتتكلم ان هو بعد 16 اسبوع ما ينفعش، في ناس تانية بتتكلم ان هو as long as البيبي هيسفر وفي suffering قبل كده هو موجود ف you can't terminate pregnancy. فده religious concept. نيجي بعد كده هو ليه legal concept. لازم نبقى فاهمين كلنا ان induced abortion as long as it is not maternally indicated is illegal. Once there is something wrong happened to the mother during the process of abortion, induced abortion يعني you can be sued as an illegal procedure. فده becomes a little bit of a tricky point. فدايما مثلا الحالات ديت بنوديها للجامعة بحيث ان الموضوع يبقى covered بحد ب bigger community. ثالث بقى نوع هو او ثالث حاجة هو fetal indication for termination of pregnancy. From my point of view, this is my own opinion. In once you have a lethal anomaly. Lethal anomaly is, for example, a chest hypoplasia, severe chest hypoplasia. Severe chest hypoplasia, the baby will die immediately after delivery, and there is no chance for this baby to continue his life. ده becomes a problem عشان الchest hypoplasia ممكن يبقى associated مع the skeletal anomaly، ممكن يبقى associated مع polyhydramnios، ممكن يبقى associated مع مشاكل الأم مثلا لو كملت البريجنسي بتاعها. فكان يعني بيبقى في بقى كلام baby lethal و this is a maternal morbidity condition that will continue and affect her. مثلا مع polyhydramnios يجي postpartum hemorrhage، ممكن يحصل complications مع postpartum hemorrhage. There should things could happen wrongly, diabetes, preeclampsia with pregnancy and so on. But there is no need to continue pregnancy with this condition. فده lethal anomalies. Lethal anomalies some منها cardiac anomalies. anencephaly مثلا هو most common يعني anomaly اللي احنا بنفكر فيه دايما كlethal condition. اي حاجه تانية بقى مش lethal الديبيت موجود. ما فيش حاجه اسمها this is an indication or this is not an indication for termination of pregnancy. It is better to leave pregnancy to continue as it is. It is better to see once there is a maternal there is a maternal indication for termination, you can terminate pregnancy. انما ال conditions بعد كده هو it becomes a lot of opinions. والموضوع لو هنفتحه ممكن نقعد فيه ساعات نتكلم، كل واحد يقول رأيه الخاص فيه. هل هو هل هو محسوم؟ للأسف لا. ردا على الدكتورة cystic hygroma with bone abnormality is not an indication for termination of pregnancy for whatever reason يعني زي ما احنا اتكلمنا. once you have ماشي osteogenesis imperfecta مثلا البون anomaly اللي موجود فده معاه severe chest hypoplasia، ممكن نتكلم في الموضوع ده although this will not be very apparent عند 15 اسبوع يعني لو هي بتتكلم على 15 اسبوع. نصيحتي مثلا for this patient cystic hygroma with a bone anomaly, this usually will develop into hydrops fetalis. Hydrops fetalis usually will be associated with a lethal condition intrauterine, so most probably the baby will die intrauterine fetal death, and once this happens terminate pregnancy وخلاص. Wait for pregnancy to take its own turn. انما ردا على السؤال ده مفيش رد سهل ولا رد صريح في الموضوع ده، ما بيمشيش الموضوع كده خالص للاسف. طبعا راي حضرتك دكتور حسن. اميوت بس دكتور حسن.
الحقيقه انا سعيد جدا بهذا الراي اللي حضرتك بتقوله، لان انا يعني تقريبا عندي نفس الراي ده. ودايما بقول انه الواحد فينا كل ما بيكبر في السن وياخد خبره اكتر او يعني سنه يكبر بيبتدي يبقى اكثر حكمه في اخذ القرار. واللي انا سعيد بيه حقيقه دكتور هشام انت وصلت للحكمه دي في سن صغير قوي يعني والله. يعني الناس بياخدوا علينا ان احنا دايما بنقول لهم لا ما تستعجلش وما تقولش ابدا فور ترمينيشن، وما تنصحش الام ابدا انها تعمل ترمينيشن يعني. وبعدين في نقطه ثانيه الحقيقه صغيره احب اضيفها لراي حضرتك، انه الفيلد اوف فيتال ميديسن ده فيلد صعب مش سهل. ويعني كل ما بنكبر بنشوف فرايتيز احيانا ما شفناهاش قبل كده بعد 20 و30 سنه شغل يعني. وبالتالي ما نقدرش نقول ابدا ان احنا وي ار اكيوريت 100%، ما حدش يقدر يقول على نفسه كده ابدا. سو ذات النقطه دي نقطه احتمال وجود خطا ولو قليل جدا لازم نضعها في الاعتبار وما نحطهاش ضمن قرار، ما ناخدش قرارنا ان احنا شخصنا 100% ولازم نعمل ترمينيشن. الحقيقه انا سعيد جدا انا عندي 4 اسئله تاني ما هماش اسئله، كلهم ريكويستس انهم عايزين المحاضره وكلهم ضغوط على شركه ديفارت لاب. والحقيقه انا سعيد فعلا المحاضرات دي محاضرات قيمه جدا. بعد اذن حضراتكم لو تسمحوا لنا اننا ندي نسخه للزملاء الاطباء اللي حضروا معانا النهارده لانها الحقيقه فعلا محاضرات قيمه. انا بشكركم جدا واشكر الدكتور احمد نصر والدكتور هشام الحقيقه على الليله الجميله دي، اسعدتونا وتعبتوا معانا كتير. متشكرين خالص.
شكرا.